fellow nurses, welcome to the video. I know you're out there. I can hear you breathing. Let me ask you a question. Has this ever happened to you? Here you go, Mrs. Johnson. I brought you your pills. Oh, thank you, dear. You are so sweet. What a great nurse I am.
The next day.
Good morning, Mrs. Johnson. I brought you your pills. Get the out of my house. What? It was you, Johnny. It was you that turned the cat into the dog and took the seven babies all the way to Tuscaloosa. Yeah, that's right. The normally pleasant, alert and oriented Mrs. Johnson comes at you like a crazed spider monkey with a toothache. So, what's going on here? Well, this is acute delirium.
Bruh.
Delirium is a condition described by a sudden change in the brain that causes emotional disruption and mental confusion.
And unlike dementia, which has a gradual onset and occurs over a long period of time and is irreversible, delirium has an acute onset and is usually reversible.
You're crazy.
Delirium is classified in three different ways. There's hyperactive delirium, which is agitation, aggressiveness. There's hypoactive delirium, which is lethargy and withdrawn. And then there's mixed delirium, which is obviously a mixture of both. Now, we don't see the word delirium used in our medical charts and things like that, because really it's a psych term. It's more descriptive. We see things like encephalopathy, organic brain syndrome, but trust me, it's all the same thing. The meanings are the same. And since in the subacute setting, over 25% of our patients will experience delirium, it's worth talking about. Let's go.
Well, we're waiting.
Now, there's a couple of things to note about our mean resident population and delirium. Number one, people over the age of 65 are especially susceptible to delirium.
Although people of any age are at risk of delirium, the elderly are at greater risk because aging and age-dependent structural changes inevitably affect the brain's functional reserve.
Coupled with a natural progressive breakdown of the blood-brain barrier.
All blood vessels are lined with endothelial cells. There are gaps to let molecules out of the blood vessel and into other tissues. But the endothelial cells that line the brain's blood vessels are really close together. That means only certain molecules can slip through and get out into the brain tissue.
This breakdown, which previously blocked molecules too large to get into the brain, can now let them in, causing brain dysfunction. What does every concerned family member say when their mom starts talking to Jesus or thinking they're on a cruise ship to the Bahamas? Hey, my mom's talking crazy. I think she's got a urinary tract infection. And they would be right, about 15.4% of the time. I feel like this is an acute care setting statistic. I think that number is higher in the post-acute setting. But the point is, it's not always infection. In fact, the top three are pre-existing medical conditions, medication, and infection. That's why That's why your assessment is so important. So let's talk about it. Okay, so let's talk about delirium and infections. I'm not going to spend a lot of time on this because I think this one is fairly obvious to most of us. I mean, infections have a host of symptoms that are easily recognizable, and delirium only being one of them. UTIs, you've got the frequency, burning with urination, that UTI smell. Pneumonia, you have congestion, lung pain, there's fevers. Wound infections, of course, there's edematous, redness, heat, maybe drainage, all that stuff, right?
Yeah, I give you a UTI.
Infections are like really dumb criminals because they leave all this evidence behind that they're the ones who did it. So, because of infection, you have now what they call a sepsis-associated delirium, or SAD. Aww. So what do? Well, the doctor prescribes an antibiotic and things should clear up, right?
I have exorcised the demons.
Not so fast.
What?
Even some antibiotics can cause delirium. Although the figures are pretty low.
Ertapenem
Being the biggest offender with only 3 to 5% of elderly patients who take it developing delirium. But still, that leads us into the next part of this. Drugs. Oh, boy, what a rabbit hole this turned out to be. Suffice it to say, there's a number of medications that can contribute to delirium depending on diagnosis or circumstance. But for this video, I'm just going to concentrate on the big three, okay? Now, what medication classification is the undisputed heavyweight champion of leading to delirium? That's right, opioids. Opioids sail right past that blood-brain barrier and attach themselves to opioid receptors at the end of nerves, blocking pain signals from the body to the brain. Now, I've always thought that opioid-related delirium was caused by lack of oxygen perfusion to the brain because opioids depress the central nervous system, right? Slow down your breathing. Turns out that's really not the case. Opioids also spike dopamine. That's the feel-good neurotransmitter, and too much of a good thing is never a good idea. Turns out your body really likes its neurotransmitters in balance, and too much dopamine can lead to delirium. So, what's drug classification numero dos? You know them. You love them. Benzodiazepines. God, why do I always say peens? It's peens. Benzodiazepines. I think I got a urinary tract infection. Anyway, benzos, that's much safer, increase the amount of a neurotransmitter called GABA. And GABA is the slow down, chill out neurotransmitter in the brain.
Relax, take it easy.
But just like opioids and dopamine, too much of a good thing is never a good idea.
So, in response to the presence of a foreign chemical, the benzodiazepine, the body adapts with a series of adjustments, trying to counter or overcome it and its effects.
And too much GABA can lead to delirium. Oh yeah, and I forgot to mention, benzodiazepines can also have what they call a paradoxical effect. And I experienced this firsthand. I gave a woman an Ambien, and an hour later, she was standing on her bed, swinging a gate bell, like Leonidas from the Spartans, ready to do battle with the Persians.
This is Sparta!
So, what's drug classification number 3 known to cause delirium? How about anticholinergics? Warning, this is Mike from the future here. I'm about to mispronounce the word anticholinergic as anticholinergenic 1,000 times. So if you find this triggering, I don't care. I'm not reshooting the video. Yeah, I was surprised too. But it makes sense when you consider that anticholinergics block the action of acetylcholine in the parasympathetic nervous system, relaxing smooth muscles.
You have anti-acetylcholine. You have systemic blockage of acetylcholine throughout the body.
So there you go, messing around with those neurotransmitters again.
What's anticholinergic? How do I know what's anticholinergic? Well, we have a list. There's a Beers list of medications that can be problematic.
And there's a lot. A number of them have been phased out, like tricyclic antidepressants like nortriptyline and amitriptyline. You don't see those very much anymore. Or first generation antihistamines like Benadryl, diphenhydramine, and chlorpheniramine. There's better antihistamines like loratadine and stuff like that that aren't anticholinergic. But there's still a lot of anticholinergics that we use. Bronchodilators like, I'm going to try to say this right, ipratropium. You know what I'm talking about. Muscle relaxers, Flexeril, Ditropan. There's still a lot in use. But if you get too much, there's something called anticholinergic syndrome that can occur.
Anticholinergic syndrome is a condition that can occur when anticholinergic agents build up in the body and block acetylcholine receptors. This can cause a range of symptoms, including confusion, delirium, and hallucinations.
I've got to say I've had 2 kids and I can't jump on a trampoline anymore, but you know, we do our Kegels and we work on it.
Okay, good luck with that, Liz. All right, let's talk about what I feel like is the most important thing when it comes to acute delirium, and that is pre-existing medical conditions.
Oh, I have a medical condition, all right. It's called caring too much, and it's incurable.
Now, bear with me here. Since there are so many pre-existing medical conditions that can contribute to delirium, I'm going to try to narrow it down to the ones we see the most. I'm going to cherry pick here, and hopefully I hit on a lot of the ones that we see. Maybe I go organ by organ. Yeah. Let's start with the heart.
Congestive heart failure.
Cat. Say hi, Shadow, Kitty. Yeah, whatever. Anyways, I know we all know what CHF is, right? Or at least, I hope we do. But for context, let me do a brief synopsis, okay? So the circulatory system is a pressurized system, right? It requires a constant level of pressure for blood to circulate throughout the body and do all the things it needs to do. Now, when that pressure is too high, it can cause the heart to work twice as hard or more than it needs to. For a long period of time, this battling against high blood pressure can lead to something called cardiomegaly, which is an enlargement of the heart. An enlarged heart is a very inefficient heart. Now, stress on the ventricles of the heart can cause the body to release something called, let's see if I can say this right, B-nutriatic
B-type natriuretic peptide.
BNP. And what's BNP's job? Well, it decreases the permeability of the endothelium. So you can end up leaching fluids to lower your blood pressure into your tissues. That leads to lower extremity edema. CHF also causes blood to back up. It's like a traffic jam.
Hey, merge! Merge! Don't you know how to merge? Come on!
Leading to congestion, shortness of breath, and of course, poor oxygen perfusion. An exacerbation of CHF, or when the symptoms or the ill effects of CHF get so bad that you need to seek medical attention. 1 in 3 people with an exacerbation of CHF experience delirium. Now, why is that? Well, let me tell you. Most times it's because poor cardiac output leads to cerebral hypoperfusion, right? You don't get enough of that good stuff, that good oxygen to the brain pan. In the post-acute setting, we see people post-crisis, right? The exacerbation has been stabilized and we're trying to get them stronger so they can go home. But they're still at risk for delirium, and there's a number of reasons why. In the post-CHF exacerbation patient, you want to ideally control fluid volume. You don't want a re-exacerbation of the CHF, and you don't want them blowing up like balloons with lower extremity edema. So how we handle this, or how the doc handles this, is fluid restriction and diuretics. And both of them can lead to delirium. How? Well, this is how. These dual therapies can lead to dehydration. And dehydration can cause delirium. And the use of diuretics can cause hyponatremia. And a low sodium can also cause delirium. So watch those kidney function tests, those BMPs. Look out for that high BUN creatinine ratio to indicate dehydration. And watch out for that low sodium.
We need salt in that.
All right, let's talk about the lungs.
Chronic obstructive pulmonary disease.
I'm sorry, can you stop breathing so loud, honey?
COPD is a group of lung diseases that cause breathing problems and restricted airway, namely emphysema and chronic bronchitis. Smoking or long-term exposure to environmental pollution can lead to damage to vital lung tissue. Now, to paraphrase here, inflamed bronchial tubes and damaged alveoli lead to lung hyperinflation and poor gas exchange. And when it comes to breathing, it's all about the gas. Sorry, I'm 55 years old and fart jokes are still funny to me. Sue me. So, how does COPD lead to delirium? Well, number 1 is hypoxia. Most COPDers are on supplemental oxygen to keep their SATs, I think the low threshold is 85%, to keep them from becoming hypoxic. But wait, too much oxygen can be a problem too, because if your SAT goes above, I think the high threshold is 95, you can become hypercapnic.
Hypercapnia, hypercarbia, is when you have high levels of carbon dioxide in your blood.
And get respiratory acidosis. And that also leads to delirium. The third thing is maintenance treatment for COPD is bronchodilators and inhaled steroids. Remember bronchodilators? Those are those anticholinergics. And they can lead to I'm not going to say it. Anticholinergic syndrome. That's right. Now, delirium can be tough with COPDers because they often feel dyspneic even if they're not hypoxic. This is because hyperinflation of the lungs, it depresses down that diaphragm and they have to use accessory muscles to breathe. They often feel like they can't catch their breath. They want you to crank up that oxygen.
All right, let's not get into panic mode!
But that's the wrong thing to do. Usually finding a way to calm them down, reminding them to purse lip breathe and that kind of thing, that's helpful. But don't crank up that oxygen. That's bad juju. Okay, let's talk about the king of the filter organ. Let's talk about the liver.
Cirrhosis of the liver.
The liver is pretty amazing. Not only does it filter all the blood and break down poisonous substances, but I feel like the body said, I don't know who else is going to do this stuff. Let's ask the liver. Hey liver, can you convert nutrients into stuff the body can use and then store them and supply them when the body needs them? Yeah, sure, I can do that. Can you produce bile that convert fats into energy? Yeah, no problem. Hey, can you also produce albumin that helps transport hormones, drugs, and fatty acids? No sweat. Can you also store fat-soluble vitamins, iron, and copper? I mean, I guess on the weekend. Can you also detoxify bad stuff and make them into harmless substances? In my spare time. There's no doubt. The liver's a badass, doing the heavy metabolic lifting for the body. But over a lifetime, over-consuming fats, sugars, and alcohol can scar the liver. There's also a virus called HCV that causes the disease hepatitis C. And it's a tough one. It's a bloodborne pathogen, and its route of transmission is from cell to cell through the cell wall, so it's incurable. And we're at risk because we're in the healthcare profession. And I don't know what is going on with the hair over here, but anyway, all these things can lead to cirrhosis of the liver.
If certain reasons cause inflammation of liver and liver cells could not work properly, the liver function will be disturbed and result in formation of scars in damaged area that permanently damage the liver. This condition is called liver cirrhosis.
So, how does a damaged liver contribute to delirium? The body produces ammonia, right? Primarily in the breakdown of proteins during digestion, and that ammonia is toxic. So the liver converts that ammonia into urea, and you pee it out. With a damaged liver, it can't do that. Dangerous levels of ammonia will build up, and they'll cause you to get a little crazy, you know what I mean?
Is serious. We could make you delirious.
So what's the treatment for hepatic encephalopathy? Well, primarily it's lactulose. Lactulose helps draw ammonia out of the blood and into the colon where the body gets rid of it. I think also, and don't quote me on this, but I think lactulose, because it's a stool softener, it helps pass some proteins before they're broken down, decreasing the amount of ammonia in the body. Not entirely sure of that, but I think so. Anyway, there's also an antibiotic called rifaximin that reduces the bacteria in the gut responsible for protein breakdown, thereby lessening the amount of ammonia produced by the body. That's worse. Anyways, let's talk about the kidneys.
Acute kidney injury and chronic kidney disease.
Now, the kidneys are another example of a filter organ or set of filter organs that are working overtime. Not only do they filter toxins, drugs, and excess fluid from the blood, but they also maintain a healthy balance of water and minerals. In addition to that, kidneys release hormones that control the blood pressure. Now, just like the circulatory system, the structures of the kidneys require a certain amount of pressure in the system to perform their job.
Blood pressure inside the glomerulus must be high enough to enable filtration.
Acute kidney injury is a sudden or serious decline or complete failure of the kidneys. And there's a number of conditions that can cause this. Sepsis, liver failure, dehydration, diabetes, low blood pressure. I feel like the one we see the most is hypovolemia due to sepsis, dehydration due to vomiting and diarrhea in the septic patient. We also occasionally see blockage of urine from kidney stones. We also see rhabdomyolysis, which is the breakdown of healthy muscle tissue that releases a toxin called myoglobin that affects the function of the kidneys. Now, how does AKI cause delirium? Well, let's start with dehydration, which we talked about before. Now, the brain is 80% water. Shrinkage of the brain due to dehydration can cause delirium. Also, the kidneys are responsible for hormone balance, and a hormone imbalance in the brain can also cause delirium. So let's talk about chronic kidney disease. Now, the kidneys are a very complex organ. They have very intricate, delicate structures. And over a long period of time of abuse, say from high blood pressure or diabetes, these kidney structures can break down and the kidneys can no longer function properly.
Chronic high blood glucose levels, together with high blood pressure caused by diabetes, bring damage to tiny blood vessels in the kidneys, affecting their functions.
Requiring people to go on dialysis to filter their blood the way the kidneys would do. Now, the common cause of delirium in your hemodialysis patient is a syndrome called DDS, or let me see if I can remember this right, dialysis disequilibrium syndrome, which is basically an imbalance of your electrolytes. Hold up, that's not true. An imbalance in your electrolytes is absolutely a cause of delirium in your hemodialysis patient, but DDS is actually a difference between the urea in your brain and the urea in your regular blood plasma.
DDS is characterized by neurological symptoms caused by rapid removal of urea during hemodialysis.
But that can also cause delirium. And it's really more complex than that. I'm just going to leave it at that. Anyways, I think that's about it. I think we're done. Hopefully, everybody's sort of learned some things about delirium. I feel like I'm delirious right now after making this 20-minute long video. Anyways, I'm going to be doing more of these, so watch out for some more Mike doesn't know stuff, but he's trying to explain it anyway videos. All right, there we go. Later.